Leprosy rapid revision. Watch this video till the end to know all the important points from exam point of view related to Hansens disease. Hello dear students, myself Dr. Maddineni Srinivas. I hope these videos are helping you out. The link for the playlist is there in the description as first comment. So please do hit that like button, and if you are liking the concept of making these hyper revision or rapid revision or quick revision, whatever we call, videos on a regular basis, and also do subscribe for more such videos on a regular basis. So without any further delay, let us begin the discussion of the Hansens disease. So what is the etiological agent? It is Mycobacterium leprae or Mycobacterium lepromatosis, which is basically obligate intracellular acid-fast bacillus, which is having very slow doubling time of 12 to 14 days, and the route of transmission is primarily inhalational through the droplet infection. The organism is going to primarily target the macrophages in the skin and also the Schwann cells in the peripheral nerves. That's the reason why there's going to be sensory loss. And for the optimal growth of this organism, it requires cool body temperature where it is going to be present. That's why it is going to be present in the earlobes, where we are going to do the slit skin smear. And apart from the testis, nasal mucosa, skin and peripheral nerves are other cool areas. Clinical features, involvement of the skin and nerves are very important for you to remember. In the nerves, remember the earliest sensation to be lost is the temperature sensation, and you can see that the crude touch is the last to be lost. Sensations which are never lost are proprioception and also the vibration. These were previous NEET one-liner type of questions. That's why we are having these also in the discussion. Coming to the most common peripheral nerve which is affected is the ulnar nerve, followed by posterior nerve. Most common cranial nerve which is affected is a facial nerve. Damage to this can lead to the lagophthalmos, because of which ultimately there is going to be exposure keratitis, which is the most common cause of blindness in the leprosy patients. Again, ophthalmology point of view, this can be integrated. Most common nerve for abscess is ulnar nerve, most frequently seen in the BT leprosy, and remember BT leprosy is the most common type of leprosy in India. Radial cutaneous nerve and sural nerve can be used for the biopsy, nerve biopsy in the case of pure neuritic leprosy where there are no skin lesions on the body of the patients. Coming to some systemic organ involvement, most common renal lesion which can be present is mesangial-proliferative glomerulonephritis. Most common organs which can be affected in the males are going to be the testes, and in the females is going to be the liver. Organs which are going to be spared, they are going to be central nervous system, lungs and GIT. Remember, uterus is least involved in the woman female, and ovary is sometimes involved, right? Coming to the classification of the leprosy, it is based upon the Ridley-Joplin classification, again based on the cell-mediated immunity. So you must remember cell-mediated immunity plays a very important role in the leprosy patients. So the tuberculoid and lepromatous. So first let us see these very quickly. Tuberculoid TT pole and LL pole. In the TT pole, the immunity which is present, its cell-mediated immunity is going to be excellent. That is basically the response is going to be T helper 1 response, whereas in the LL pole, the immunity, cell-mediated immunity is very poor, and it is going to be Th2 response producing antibodies against the M. leprae, which are not any use in these patients because the antibodies are not going to destroy the M. leprae bacillus. Number of lesions are going to be few in TT pole, and they are going to be multiple, innumerable in the LL because the immunity is very poor. Skin lesions are going to be well defined, dry anesthetic macules or plaques, which are described as saucer right way up type of lesions, whereas here the lesions are going to be very ill defined, and also patients are going to have the diffuse infiltration of the face of the earlobes producing this leonine fascias. Distribution is going to be asymmetrical because there are few lesions in the TT pole, whereas they are going to be symmetrical in the case of lepromatous leprosy because they are innumerable lesions. Single thick nerve is going to be present, usually symmetrical. Multiple nerve involvement is very characteristic of lepromatous pole, along with glove and stocking type of anesthesia. Paucibacillary, obviously multibacillary, and lepromatous is going to be strongly positive. So we can say the patients that the prognosis is going to be very good in the TT pole because immunity is very good, whereas here it is negative in lepromatous leprosy. Histopathology, if you do a biopsy, we are going to see the well-formed epithelioid granulomas because cell-mediated immunity is very good. T helper 1 response is very good. Langerhans giant cells can also be seen surrounding the nose. Here the immunity is very poor, it's not at all working. Foamy macrophages, Warsaw lepra cells can be seen, which are packed with the bacillus, which are called as globi. Granzone is absent in the TT pole because the granuloma is very close to the epidermis, whereas in the lepromatous pole there is going to be a cell-free zone which is called as a granzone, right? Now coming to the other middle forms of borderline spectrum, borderline tuberculosis, most common type in India, like I've already told you, satellite lesions can be seen in BT leprosy patients. BB or mid borderline leprosy, here remember it's the most unstable form exactly present at the center, and the patients are going to have lesions of the skin which are having inverted saucer shape appearance, and at the center you can see the Swiss cheese appearance or punched out appearance. And also remember geographic map like lesions are going to be very characteristic of BB leprosy, and it's also called as dimorphous leprosy. Borderline lepromatous leprosy, here remember almost a symmetrical involvement of skin and nerves is going to be the characteristic point. Indeterminate leprosy is a very close differential for pityriasis alba. If you remember in the children, if they're hypopigmented lesions, so you should think of P alba and also indeterminate leprosy. Indeterminate leprosy, the patients are going to have usually single ill-defined hypopigmented macule with normal sensations. Okay, histopathology may show periadnexal and perineural lymphocytic infiltration. Pure neurotic leprosy will not have any skin lesions, and we have already seen which nerves to do biopsy for. Histoid leprosy, it's a severe variant of the lepromatous leprosy because of the dapsone resistance, which was earlier the monotherapy which was used in the patients of leprosy, and it presents with spindle shaped histiocytes in the biopsy. Very important point to be remembered. Lucio phenomenon, lepra bonita. It is a diffuse lepromatous leprosy, again a variant seen in Mexicans, presents with shiny face without any wrinkles. That is the reason why it's also called as beautiful face. And severe necrotizing cutaneous ulcers is very characteristic feature of this condition, Lucio phenomenon. Coming to the investigations, slit skin smear is going to detect the acid-fast bacillus. The smears are taken from minimum 3 sites. So one earlobe and two other are active lesions. So best site in untreated cases is going to be the earlobes, whereas in the case of treated cases, dorsa of the fingers is the best site. Slit skin smear is going to be positive only if there are 10,000 bacillus per gram of the tissue which you are doing, and it is often negative in TT and indeterminate forms. So BI and MI, bacteriological index, morphological index, this concept you should know. BI is going to detect and count all the bacillus dead and alive, both of them put together, total bacillar load. So that is the reason why it's going to remain positive long after the treatment is completed, whereas morphological index is going to only measure how many live bacillus are there, which are going to stain solid. So that's the reason why it is best indicator for measuring the efficacy of the treatment which you are giving with the medications, and it's going to become negative after successful treatment. Biopsy is the gold standard for the diagnosis, and its special stain which we are going to use is Fite-Faraco stain. Remember, acid-fast bacillus Z Nielsen stain is for the smears, and for biopsy we are going to do the Fite-Faraco stain. Lepromatous, we have already discussed this. It's a prognostic test, it's not a diagnostic test. Very important point to remember. And it has two responses, reactions we can say, readings Fernandez and also Mitsuda, early and late. World Health Organization NLP classification, multi-drug therapy. So how are we giving this multi-drug therapy? Based upon whether they are patients of PB or MB. So those patients who are having 1 to 5 lesions without any nerve involvement and without any SSS, we categorize them as paucibacillary. And those are having more than or equal to 6 skin lesions and also 1 thick nerve and also positive SSS, we are going to categorize this patient as multibacillary. Even any one of them, if it is present, we are going to categorize the patient as MB patient, and we are going to give the same 3 medications for both these patients, rifampicin, dapsone, clofazimine, but only difference is duration. In the case of PB patients, the duration is 6 months, whereas in the case of multibacillary, the duration is 12 months. Right? And what are the dosages? This is also very important to remember. Rifampicin is once a month dose of 600 mg under supervision, and it's highly bactericidal medication. Coming to dapsone, it is 100 mg given daily, whereas clofazimine, remember, it is the given both once monthly and also daily. So one monthly dose is going to be the half of the rifampicin dose, that is 300 mg, and daily dose of clofazimine is going to be half of the daily dose of dapsone. So very easy to remember. Side effects, remember, rifampicin, the patients are going to complain of red orange discoloration of the body fluids, and it is also hepatotoxic, if you remember. Dapsone is hemolytic. G6PD deficiency, if it is present, it can cause hemolysis. Methemoglobinemia, dapsone hypersensitivity syndrome can also occur, which is the 5th week syndrome. Clofazimine is going to cause the skin to become coppery red pigmented, and also dry skin ichthyosis can also be one very important point. Coming to the lepra reaction, remember the leprosy is a very chronic disorder, but in that there are going to be some episodes of acute inflammation which are because of the immunological shifts. Remember the rule of thumb, never ever stop the MDT during a lepra reaction. And what are the lepra reactions you have to remember? There are two important 1 and 2 lepra reactions. Type 1 reaction is also called as a reversal reaction, whereas type 2 is called as erythema nodosa leprosum. Remember, type 1 lepra reaction is a type 4 hypersensitivity reaction, that is cell mediated immunity, whereas this is immune complex mediated type 3 hypersensitivity reaction. And it is seen in the borderline forms, the BT, BB and BL, whereas here it is lepromatous pole, BL and LL. So the pre-existing lesions are going to become inflamed in the case of the type 1 lepra reaction, whereas here new lesions are going to be produced because of the deposition of these immune complexes anywhere in the body, and it's going to even affect the other organs systems. And fever, arthralgia are going to be very severe in the type 2 lepra reaction patients. In the type 1 lepra reaction, the neuritis is going to be very severe, which may sometimes need IND because of the excessive nerve abscess formation. Steroids are going to be the drug of choice in both the cases, whereas thalidomide has a role in type 2 lepra reaction. It's the fastest acting drug. It is going to suppress the tumor necrosis factor alpha, but the problem is it is teratogenic and also it is very expensive, and it is avoided in pregnancy. That is the reason why it is not the drug of choice, though it is fastest acting, and because of this phocomelia is going to be produced. And in the pharmacology, you might have read the usage of the thalidomide in pregnancy. Previously it was used for one condition. What was that? Put your answer in the comment section if you know that use indication in the pregnancy for which it was used, because of which there is phocomelia developing in the children. Now coming back to this topic, prophylaxis and NLEP. So chemoprophylaxis with single dose of rifampicin of 600 mg for adults can be used. What are the criteria to be fulfilled for this? They should be close contacts with the cases, living or working for more than 20 hours per week for minimum of 3 months, and must be 2 years of the old and elder. Immunoprophylaxis MIP, Mycobacterium indicus prani vaccine, can be administered to the contacts and also to the cases along with the MDT as a part of immunotherapy for faster bacillary clearance. SAPNA, this is a PSM topic. The official mascot for the NLEP, National Leprosy Eradication Program in India, is aimed at spreading awareness in the rural areas. So I hope this video is helpful. So please do the like button. If you have any doubts, you can put them in the comment section below. And did we discuss any question in this video and you have answered it correct in the comment section? I will comment like for that comment. So subscribe to the channel if you're not yet subscribed, and thank you so much for watching till this point. Happy learning. Sarvam Sarkishan from Sarvechana. Sukino Bhontu. Thank you so much. Bye bye.